Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Ask Dr. Gerdisch Anything. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. The mission of our website is really simple. We want to educate and empower patients just like you. And this webinar, which has had over 400 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen only mode, but I'd encourage you to submit your questions, as many of your questions as possible in the control panel that's on your screen. The agenda for today is very simple. I'm going to introduce our featured speaker, and then we are going to ask Dr. Gerdisch anything. I'm going to conclude this session by asking you to complete a very quick 5-question survey. And so when it comes to our featured speaker, I am honored and humbled that he is taking time away from his very busy practice in Indianapolis, Indiana. Who is he? His name is Dr. Mark Gerdisch. He's the chief of cardiac surgery at Franciscan Health in Indianapolis, Indiana. He has performed not 1,000 or 2,000, but 7,000 cardiac procedures, of which 5,000 have involved some form of heart valve repair or heart valve replacement. When it comes to his specialties, he is a minimally invasive specialist and a rapid recovery expert. And we're going to talk about that today. Another bullet point that I'd put on the slide is Dr. Gerdisch is an innovator in the field of heart valve research. Dr. Gerdisch has helped a lot of people in our community. He has over 141 patient reviews. He's helped folks including Todd Runenbaum and Matt Shute and Linda Kincaid and Janelle Hurst, Dan Roden. His patients go what I call gaga for Gerdisch. You can see they even put together t-shirts when they're on the tennis courts that say powered by Team Gerdisch. So we can talk about his accolades. We can talk about his research. We can talk about his achievements. This is something else I want to share with you. These are patients of Dr. Gerdisch's that are going through recovery. Some on the left, you'll see, are early in that recovery in the hospital. And then you'll see you've got someone like Matt who's hitting a softball or a baseball there, and he's in his 3rd week of recovery. So it is fantastic. I want to welcome Dr. Gerdisch to our webinar, and I also want to thank him. Together, Dr. Gerdisch and I have been on a nearly 15-year journey of education and empowerment. And Dr. Gerdisch, I can't thank you enough for all the support you have given our community. So thanks so much for being with us today.
Oh, thank you, Adam, and congratulations for having this kind of level of impact. Has it really been 15 years that we've known each other?
It has, yeah.
Oh my, it goes really quickly, doesn't it? But
It
yeah,
really.
that's fantastic. Fantastic. And yeah, my shout out back to the community for everybody getting on and learning as much as they can and helping us sustain knowledge at the level outside of our operating rooms and academia. So good.
All right. With that said, Dr. Gerdisch, are you ready to get into a rapid fire session of Q&A? Let's kick it off with a great question right to your specialty, which is all about rapid recovery and a protocol. Tom asks, are there any new updates on Dr. Gerdisch's rapid recovery protocol? On the left, I know you've been doing some work in operating room ventilator removal, and then I know there is some real exciting stuff about a new tube that's helping. Can you talk about that for Tom?
Sure. So yeah, these are both kind of interesting representative pictures in the sense that that tube on the right is just a chest tube. And one of the things that kind of drove me nuts for a long time was that for 70 years, we'd use the same archaic chest tubes. We'd use these plastic tubes to drain the chest and never really knew if we were fully clearing the chest. And we didn't have a mechanism for keeping them patent. And when it was studied, more than 2/3, close to 80% of chest tubes were clotting. But for all these years, we've just kind of done this kind of mechanical manipulation of them and fretted over them. Finally, a team came out with a tube that has a mechanical mechanism for clearing the fluid. So there's a little wire that goes up through the tube, has a little spiral at the end of it. And so we're always sure that we're getting the chest tube's open. Well, that sounds like a simple thing, and it might not sound as important, but it's incredibly important because when people retain any blood products in their chest, number one, you don't know that the blood is there and could be causing trouble right after surgery. Number two, if it stays there for a while, it causes inflammation, it causes fluid to accumulate, it makes a patient feel unwell. Inflammation. So with this tube, when we brought it on, because it's as we do with everything, when we bring a new device on, we study it. So we studied this tube for a year, collected continuous data, and compared it to another year of similar patients done by the same surgeons, the same operations, in the same quantities. And it was absolutely remarkable what we found with decreases. We had a 1 day length of stay decrease. We had huge savings in blood transfusions. We had less overall drainage. We think that's because when you keep the blood out of the chest, that promotes healing and closure of small vessels and diminishes the inflammation. And so, as a consequence of all that, and decrease in perioperative atrial fibrillation as well, but as a consequence of all that, when we recognized that with this tube, we were very confident about whether there was any continued bleeding, and we knew that we were able to manage the fluid in the chest. And it was one of the things that contributed on to the thing on the left, which is, as many people know, last year we published a paper showing that we could do sternotomy heart surgery, not just our minimally invasive cases, which forever we've not had to use narcotics because of our intercostal block, but sternotomy patients, because of the way we manage the sternum, we don't use narcotics anymore. Well, at the same time, we eliminated sternal precautions. In other words, people can use their arms immediately after surgery, get up and down from a chair, up and down from the toilet, up and out of bed, which also meant they went home. So essentially, everybody goes home instead of an extended care facility. And then the next step for us was to get the tube out of their mouth because people don't like to wake up with that. So now we have a median time to extubation of 0 hours, which means the majority of our patients have the tube out of their mouth. Doesn't matter if it's a sternotomy or minimally invasive, the tube is out before they leave the operating room because we've kind of equalized the experience no matter what the operation. So for me, it's always kind of been, well, okay, I love to do minimally invasive surgery, but I can't do that for everybody. And what do I do for the triple valve maze? What do I do for that patient? We figured it out. And so we marched toward this process where everybody looks the same. Median time to extubation, 0 hours. You can use your arms right away. You could drive when you feel like it. We don't have any restrictions on that. So those are the things. Basically, what we did was we built on what we've already accomplished. We added a little bit more technology, and then recognizing the opportunities, we took full advantage of them. And so we've really kind of expedited some of the things that, and the other thing is, I mean, people recover better and faster if you can get the tube out of their mouth and get them up sitting and walking immediately. So all of those things have kind of happened as a natural progression from the work we were already doing.
Yeah, and Dr. Gerdisch, as a patient who woke up after my own heart valve surgery, not knowing there was going to be a ventilator tube in my body, that was incredibly uncomfortable. And so I want to thank you and your team. I know this takes a village to come up with this research and test and retest. So thanks for everything you're doing to make a experience for a patient much more comfortable. Let's
Yeah,
move
very
on.
much a team X. It's very much a team experience. You're right.
Yeah, so let's move on to another passion, interest of yours that will come out in Derek's question, which was he said, I saw Dr. Gerdisch's videos about scaffolds for recreating the leaflets for tricuspid valves. Is this going to be available for bicuspid aortic valve patients?
Right. So we've been kind of knocking on this door for quite a long time. As you know, we are closing in on the end of our FDA trial with the regenerative tricuspid valve, which is super exciting for us. And of course, we want to eventually traverse into the other valves. If I kind of give you hopefully only 2 minutes of this, because I know we have a lot of questions, but this is a passion of mine. I think this is a field that we need to stay on and focus on, even though engineering in valve surgery and valve technology kind of takes us in a different direction in general, which is like the next TAV or the next surgical valve. Those are constructs. We have to think about what their fabrication is. So, presently, Dr. Yacoub, one of the most famous heart surgeons on the planet, he's not doing heart surgery anymore, but probably he may have done more heart surgery than anybody else, who's based in London. He actually has a valve that is considered to be a scaffold that will regenerate tissue that is going into some patients right now. Um, I, I know some about that fabrication. I think it's super interesting and unique. I was just in Zurich visiting, and while I was there, I visited a friend of mine, Max Emmerich, who's a brilliant surgeon at Berlin Heart, who also runs a tissue engineering lab in Zurich, and I looked at the work that they're doing. So they're actually essentially culturing human extracellular matrix, the material that we use from the pig, and then they're decellularizing it and making constructs out of it. And in their bioreactors, they're adjusting the fabrication of these constructs. And then there's the work we're doing, which is where we take an adaptive matrix, a matrix from the small bowel of a pig, and then we completely decellularize it, and we use that as the framework for the stem cells. So those are the pathways that are being run down. Are we going to end? When will we end up with an aortic valve? Well, I would take you on one other tangent. There have been a few cases where the aorta of the same human being, the wall of the aorta, was used to rebuild leaflets, like entire leaflets. Now, I've done a few cases where I've used it as a patch on aortic leaflets. I have not replaced entire valves, but it has been done. So we're going to see where that takes us. I mean, that's very exciting. It's your own tissue. And what are you trying to achieve with that? You're trying to achieve something better than the current tissue valves, which in a sense that shouldn't be too hard because those are tanned, glutaraldehyde treated, dead tissue, whereas we'd have a living substitute. So I do think we're going to get there. I think we're going to get to the left side of the heart. We're going to get there probably with a version of our scaffold. I think the folks in Zurich will have something. I think that it'll be interesting to see what Dr. Yakub's valve does. And meanwhile, people are still kind of looking at engineering things in the operating room using the patient's own tissue. It might be a while yet, but I think we're going to get there.
Yeah, well, Mark, I want to just commend you for the ongoing research because you might not remember this. One of the first videos we ever did at STS in San Diego in 2011 was about extracellular matrix. So for everybody on the line, Dr. Gerdisch has been working on this for how long now, Dr. Gerdisch?
Yeah, right. Yeah, at least 15 years. Yep.
Yeah. So thank you for doing that. This is very exciting. Another topic that has come in a lot of questions, moderate aortic stenosis. And Catherine and Kathy and someone else asked about the same thing. I recently found information with regards to moderate aortic stenosis. I read that further findings regarding this stage reports that aortic valve replacement results in faster recovery and less chance of facing post-surgery difficulties than waiting for surgery at the serious level. What does Dr. Gerdisch think about this?
This is such a good question. And unfortunately, I could spend the whole hour on this, but I'm going to try to condense it because this is really important. So we have to, and that picture is a good one because it's like a sliding scale. And we have to think of that sliding scale both with respect to the actual pathology of the valve, the patient's symptoms, and the physiologic consequences for the patient. And that last one might be the most important. So what we have right now, and it's not for moderate stenosis, it's for severe asymptomatic. So we had two surgical studies, which were I think they were called Recovery and Avatar. And in both of those surgical studies, when patients had their aortic valve replaced for asymptomatic severe aortic stenosis, they had concrete improvement in their outcomes. And that had to do with heart function and survival. Now, we recently have published a similar study, which is called Early TAVR, which is for the SAPIEN valve, which is transcatheter valve. And that is in asymptomatic severe aortic stenosis. The one thing that they had that was positive was they had less readmissions after having the transcatheter valve. They didn't have better survival. They didn't have less strokes, but they did have, not statistically significantly, but they did have less admissions. And they had better quality of life scores. That's a little bit of a slippery slope. Now, I'm going to tell you why that's a slippery slope, because if you have something done to you, you tend to feel like you're supposed to feel better. So some of those quality of life scores can be a little iffy. I mean, I think that's true even if we look at the recent I think it was called a triluminate study for the tricuspid valve, where patients get a clip for their tricuspid valve or don't get a clip. Well, the ones who had something done thought they felt better. So one of the important things when we look at these studies and we scrutinize what's going on is we think about two things. Number one, is there any possibility that the fact that they're feeling better has something to do with having had a procedure where the other person didn't? Is there something to do with the way they're managed medically after that, even though it's standard of care in both groups? I'm not saying that's what happened. I'm saying that we have to think about that. And if we want to really understand it, we need to look at the heart muscle itself. So when we talk about aortic stenosis, I have seen patients with severe aortic stenosis who have beautiful left ventricles that relax perfectly. They're not thickened. The patient's asymptomatic. They're able to do all their normal things. They don't have changes in what we call global strain. They don't have evidence of what we know is the result of histopathologic changes in the muscle. If you don't see those things, then it's probably not an advantage to jumping in there. But if we're sophisticated and nuanced about the way we look at it, when the patient isn't having symptoms, but they have an elevated gradient, and we see that the ventricle has started to thicken, or there's evidence of fibrosis, or the left atrium's enlarged, or they're having atrial fibrillation, or something's going on, then we should take it more, we should be more serious about it. So I think what this is for us is a call to be very sophisticated and nuanced in the way that we evaluate and judge the severity. Because there's another animal out there, it's called low flow, low gradient severe aortic stenosis. Well, what is that? That's a low gradient severe aortic stenosis. In other words, the gradient doesn't get up to 40, but maybe it's 25, but they call it low flow because the stroke volume index may be diminished and the amount of blood that gets pushed through the valve. Well, it becomes very nuanced to understand what is really driving that. Is it changes in ventricular performance or function? Are there other characteristics of the heart that contribute to that? So I'm going to finish by just saying, no, moderate aortic stenosis is not supposed to be treated at this point. Yes, severe asymptomatic even. We learned this in mitral valve regurgitation, right? Severe asymptomatic aortic valve stenosis that's genuinely severe should be definitely given consideration for treatment. But again, a nuanced approach to the patient's, what the real lack of symptoms are and how their ventricle is performing. Sometimes people are asymptomatic, you put them on a treadmill, they get short of breath.
Dr. Gerdisch, we're going to go right to Duncan's question that came in. I'm hoping this is going to be a quick one because we're going to get to another question about mitral regurgitation. Duncan asks, how often should I have a follow-up echo after surgical aortic valve replacement?
So it depends if you had a tissue or mechanical valve. And it also depends if you're having any symptoms and who your cardiologist is and what your heart looks like. So the simple answer is that with a tissue valve, there's a little bit lower threshold for repeating echocardiograms. But the standard, the minimum, the requirement is that every 5 years you have an echocardiogram unless you're symptomatic. Some people get one every year anyway, just because they can and because they want to see what's going on with the valve or any changes in anything. For a mechanical valve, last I checked, and that was probably a decade ago, but because we did all the studies with the Onyx valve, there's no actual clear-cut indication to have an echocardiogram after you've had a mechanical aortic valve replacement because it doesn't change. The valve never changes. So, when I did all the studies with the Onyx valve, one of the things that I did was I did a 5-year follow-up to prove that the valve looked exactly the same and nothing was happening. So it's important, and I did that again, I did that twice, that it's important to recognize that mechanical valves don't change. So if the patient's not having any symptoms, there are no issues, there's really no reason to do an echocardiogram. It's okay to get one, especially if someone is looking at something. Maybe you had some changes in your heart before you had the aortic valve replaced. You want to look at those other changes. But the valve itself should be a non-issue unless it's starting to deteriorate.
Great. Moving over, we're going to get to mechanical valves in a second, but first we have this question from Alan that came in. In describing mitral valve regurgitation as mild, moderate to severe, what specific physical parameters define one category from the other?
It's volume of regurgitation. So now, again, we'll go down a little bit of a rabbit hole here because you can measure the same person twice and get different numbers. And there are two reasons for that. It's the anatomy of the valve and their volume loading or stress at the time on the heart. But barring that, when we see a regurgitant volume that exceeds 50 cc's, we start to think of it in terms of severe. We definitely think of it in terms of severe when it hits 60. When we see a regurgitant volume of about 40, we call that moderate. When we see something below 30, we call that mild. and anything below that is insignificant. So when you get down, it's just a matter of volume of regurgitation. But again, keep in mind that it will change based on the volume loading of the patient, whether their blood pressure is elevated at the time, and how the ventricle is performing at that given moment in time. I think that's very important in the mitral. It's even more important than tricuspid valve.
Great. Let's go back now over to the discussion about mechanical valves, because this is a kind of a lifestyle question for those folks who, along with their physician, believe that getting mechanicals their way to go. Vikram asks, despite not eating high vitamin K foods, my INR drops when I travel and eat outside food as my job requires the same. I also have high triglycerides. What specific dietary or lifestyle changes should I make to keep my INR stable while managing frequent travel and a vegetarian diet?
So one of the questions I would ask Vikram is how he checks it, if he's got home monitoring and whether he's managing it that way, because I think that becomes important in people who have variability. The home monitoring is very good. I mean, most of my patients use it, but it is a little bit of a relative management strategy in the sense that it might not be exactly the same as the lab, but it will vary in the same way. So once you kind of know your spot, you keep it there with your home monitoring. I'm going to jump to the triglycerides because the triglycerides that is very important, and you should be getting specific therapy for that. And with respect to nutritional management, without getting too into detail about it, I think it's important that people recognize that the triglycerides are a signal and that fatty acid balance and lipid management, a lot of that can be managed well with supplements and with your diet. So thinking a little bit in terms of those, I think that's an important issue for him. Now, why is the vitamin K issue? Why is that happening? Why is his INR changing when he eats outside foods? Well, I mean, anytime you make, if that's a substantial shift from your normal diet, then that can impact your INR level. And it's partly because of the vitamin K. It's also partly just because there are certain foods that interact with your vitamin K processing and in your liver too. So you would want to be thinking in terms of maybe just trying to achieve that consistency by somehow keeping your vegetarian diet alive and well while you're traveling. And this becomes, a really important aspect of how you determine the impact on your life outside of the valve. So, I mean, I have friends who are vegetarian. I have lots of friends who are vegetarian, and when we travel, we just figure it out. So I think Vikram, my advice would be don't eat outside the food. The vegetarian diet is perfectly good for you. Just make sure you get a good balance and enough protein. And then I would attack those triglycerides and look a little bit at fatty acid management, some of the for example, fish oil pills. Some are very high quality. And then recently I started to look at this thing called it's called Fatty 15, which is a specific dietary supplement that looks like it has a nice tonal balance for triglycerides and cholesterol levels. But these are all things you can work with your physician on. That would be my answer.
Yeah, and Dr. Gerdisch, let's stick with mechanical valves because we get this question coming in live from Lawrence. We get this question all the time, which is, when will there be a substitute for warfarin?
Yeah, it's unfortunate that warfarin's as good as it is at what it does, because it does have to be managed. And we did do a study. We did a study with Eliquis, and it worked okay, but it wasn't nearly as good as Coumadin. So we stopped the study early. So in other words, we were still staying below the OPCs, the recommendations of, the kind of the overarching authorities that say, how many events you should have with a device. And we were still below those, but we weren't nearly as good as we were with warfarin. So that's why even with the Onyx valve, in my opinion, the most advanced mechanical valve technology on the planet, we weren't able to make that switch. There is another study going on right now in Asia with a different blood thinner. I don't know how well that's going to translate into the rest of the planet, but that is an ongoing study. So my opinion is we're going to find one. but it's going to be a while yet. And these studies take a long time, and it takes at least a few years to really understand if we've made the right move with the data. So I think it's going to happen. I can't give you a timeline on it. In the meantime, as much as warfarin gets a bad rap, it's a darn good drug, and we do have ways to manage it and keep it under nice control tightly. So that's where we are.
Great. Let's move over to a discussion that comes up again all the time, which is stroke. Ginger asks, I had an aortic valve replacement with a bovine valve for bicuspid aortic valve and aneurysm repair in 2019. I recovered completely with no issues. And then 5 years later, I had a stroke caused by vegetation growing on my aortic valve, knee, kidney, and spleen. After a 6-week IV treatment, my echo was fine. Are strokes common after heart valve surgery?
So this is a complicated scenario because most likely this valve was infected. It was a vegetation. She received 6 weeks of IV treatment, meaning antibiotics, I'm sure. And now the valve looks clean. And often, I mean, the majority of the time, actually, once you have a substantial vegetation or embolize from a vegetation, the valve can't be cleaned by antibiotics. So in a sense, she's fortunate. She's got a valve that still works okay. She's finished with her antibiotic therapy. So there are two aspects of this. One is the question, how common are they after heart valve surgery? They're not very common. But if we look at the overall data, in the first year after any valve surgery, whether a valve replacement, and quite honestly, it's whether it's transcatheter or surgical, it falls in somewhere in 3 and 4%. I mean, that's a real number, and it's a number to, obviously to be concerned about. The reality of this particular situation is that we don't know what the construct of that valve looks like now that it's had an infection on it and the infection's gone. So the question would be, are there areas on that valve that are still going to be sensitive to and vulnerable to developing clot or being infected again or whatever? So I think that it would depend a little bit on what the anticoagulation strategy is going forward, and which some folks might lean toward at least a low dose of actual anticoagulant in this person who's already suffered an event. But fortunately, it's not frequent. Unfortunately, you suffered one. When you say growing in my aortic valve, knee, kidney, and spleen, it sounds to me like probably there was embolization went to the brain, to the kidney, the spleen as well. But maybe there was some source in the body, maybe the knee where the infection started, and they cleaned that up too. I'm not sure. But that's how I would interpret that.
Great. And so now let's talk about one of the biggest revolutions in valve therapy, which is TAVR. And we've seen, I know you probably have more data than I do, but I saw it's gone from about 4,000 cases in 2012 to over 100,000 cases in 2023, Dr. Gerdisch. A lot more inclusion for this device. But we have a question from Mark about exclusion. He says, I'm 80 years old in good health except for a congenital bicuspid aorta heart valve that is now in severe stenosis. I'm told that TAVR is not an option due to change in the shape of the valve opening, CT scan verified, and excessive calcium, a 3100 score on the valve flaps. Does this make sense to you?
Makes a lot of sense to me. It tells me that the folks that are taking care of you are paying attention to the actual guidelines, and that they are interpreting the studies properly. This is actually a really important issue on a number of levels. So first of all, 80 years old, okay, fine, otherwise in good health. This is a patient that we typically would do a minimally invasive surgical aortic valve replacement for, and I agree. With bicuspid aortic valves, there are some that are nicely amenable to a transcatheter valve. And they are the ones that look a little bit more like a trileaflet valve or don't have a lot of calcium in what we call the raphe, which is the fused part. When you look at a bicuspid valve, it looks like two leaflets got stuck together, they're fused together, and then there's one other more generous leaflet that's soft and normal. When they become diseased, that part that's stuck together tends to get more heavily calcified. That is called the raphe. When it's very calcified, if you blow a balloon up in there or a valve up in there, and this is a 3100 calcium score, anything over 3000 we get very concerned about, you can actually push that raphe right through the wall of the aorta. And the other issue is that when a bicuspid valve opens, it doesn't open circular. It opens as an ellipse. You're putting a circular device in there. You can't change the shape of the annulus like we can surgically. So you end up with whole gaps on each side that result in leaks. So we know there are more leaks. We know that there is a higher chance of rupture or embolization from the valve, especially with high calcium scores. And so even if you look at the AHA ACC guidelines, the guidelines say that for bicuspid valves, it should only be for high risk patients who are very suitable, whose anatomy is very suitable. But otherwise, they should have an operation. So again, we would do a minimally invasive surgical aortic valve replacement for this patient. His team is thinking clearly on this. Um, Recently, there's been some publication looking at low risk patients, real world data for transcatheter valves. Now, we all know with the enthusiasm of transcatheter valves, they've migrated down into younger people, lower risk people. And what we're seeing is in the real world data, this was just published, that the outcomes aren't as quite as they were for the studies, not quite as good as they were for the studies. It's especially true in the bicuspid valves. So, and this gentleman Mark made it to 80 with his bicuspid valve. A lot of people show up sooner with bicuspid valves. So a lot of the people we treat that are younger are bicuspid because bicuspid valves are abnormal from birth. They tend to go through degenerative process a little bit sooner than a trileafid valve. So I covered a lot of territory there because it's important people recognize specifically to bicuspid valves that we have to be very thoughtful. And in this person's case, his team is making the right decision.
And Dr. Gerdisch, I talked about the huge swell in TAVR procedures. I also want to just ensure that all the patients on the line know that at the same time, we're also seeing an increase in the amount of TAVR explants that are happening as well. So I think this conversation of inclusion and exclusion for this minimally invasive technique is really important for the folks on the line. Would you agree, or can you comment on that?
Yeah, so again, very important, right? As the transcatheter valves are a fabulous addition to our armamentarium. I mean, it's really changed the context of management for sicker, older people for sure. And, like I said, it has migrated down into some of the younger and lower risk patients. But this all becomes part of of the strategy of lifetime management. And having taken out a bunch of these transcatheter valves, it's not easy. It's not terrible, but it's not easy. And the patient's having another operation they may not have had to have otherwise. And so they're being put at risk. And so there are multiple levels to this. First is the notion that you would put put a transcatheter valve in a younger, healthier person, puts them at risk, obviously, of needing they're going to need another operation. Next operation is probably going to be a surgical valve. TAVR in TAVR is okay, but it's not really the ideal procedure. And we also know, we know that folks who this kind of the groundswell that went into tissue aortic valves, is also kind of come around a little bit because folks were being told, well, we're going to put this valve in you now, and later we can put a transcatheter valve inside your valve later. Number one, it's not always true that we can do that. Number two, the survival after a valve in valve, in other words, a transcatheter valve inside of a failed surgical valve, is not as good as the survival of redo valve surgery. So if your tissue valve wears out, right now as the data stands, it doesn't look like there's an advantage to getting the valve in valve. Now, it's not going to be true for everybody, right? Some older, sicker folks, you get into your late 80s or something, sure, it makes sense. You put a valve in valve. But the outcomes in the other folks, and it's not subtle, although they had to do match sets, so it's not a randomized study. But the difference is so dramatic that even if the difference is half of what we saw, it's a serious problem. So it's just a matter of just being thoughtful, just like this team was thoughtful about this, about Mark. Yeah, we could do a transcatheter valve, but it might leak. We have this risk of rupture. Someone else might be a young person. Well, yeah, we can do a transcatheter valve, but what's the next step? So yeah, and take him out is increasing quickly because we have so many of them out there. And I don't, people aren't making mistakes. It's just that there's enthusiasm. There's data that suggests that the valves are functioning well. Patients, don't want to have the surgery. But I think also, as I've shown earlier with our recovery protocols with minimally invasive surgery, we've really kind of taken a lot of the sting out of the operation. I mean, it's just not what it used to be as far as magnitude of the operation, the recovery, the time in the hospital, the time, not being busy and able to carry out your normal activities. So lot of stuff there, right? And goes to, who's on your team. Uh,
Yeah, and not to cut you off, we got to get moving, Dr.
yeah, sorry.
Gerdish. We got for anybody who wants to learn more about the rapid recovery protocol that Dr. Gerdish is referencing, we did a great video. You can just type in Rapid Recovery Protocol 2 at the website in the top search bar, and you will see all about it. Let's shift gears over to mitral regurgitation treatment. Kathy asks, what current and upcoming transcatheter treatment options are there for a healthy active woman in her 70s with severe mitral regurgitation with a history of aortic valve replacement done 32 years ago and a history of rheumatic heart disease?
Wow. Yeah. So this is really an interesting case, especially if the mitral valve is rheumatic. Just had a person recently, we see this, we still actually see a fair amount of rheumatic heart disease. And the question is about the transcatheter devices. So let's start at the end, which is transcatheter devices. We now have one FDA-approved transcatheter device for mitral valve replacement. It's the Tendyne device. It is Abbott. I think it's in your pictures here, maybe. It's the top one on the left. It is put in through the tip of the heart, through a little incision on the left side. It is cleared for heavily calcified mitral valves, so a valve that might be considered very high risk for surgery. Whereas we might take that calcium out to replace the valve. Some folks aren't comfortable with that, and sometimes it is quite challenging. So it's a nice answer, I think, for people who might be very high risk for surgery. The drawback will be, for example, I have a lady tomorrow. She's 89 years old. She has a very calcified mitral valve. And the opening of that valve is very small because the calcium is impinged on the opening of that valve. So when she has her surgery, I have to take all that calcium out to put the new valve in because I need room. If you have this, the Tendyne is a self-expanding device. It's only going to fill the space in the middle of that calcified valve. So, for example, this lady tomorrow, she would not be a candidate for this because you can't possibly make the valve big enough inside that tiny little mitral valve that she has. Another person, though, might have a lot of calcium and a valve that leaks, and the valve is pretty round, and you got a nice size hole there, and the leaflets will get out of the way, and they're high risk. That might be a high risk patient, and so the Tendyne might make sense for them. Now, when a person's valve is leaking, in general, as you know, we just repair it. I mean, that's the right thing to do. Yesterday, I had a gal who actually had a big bar of calcium in her valve. We took the big bar of calcium out, reconstructed with a patch, added the patch to the back leaflet of the valve so that we rebuilt the back leaflet, and then the valve worked perfectly. So, she's off the ventilator, leaving the operating room. She's sitting up, walking around now, chatting with her family. And she's 74 years old. She's not young. She's not old. But my point is that it has to be very specific to the patient. And when it comes to rheumatic disease, as rheumatic disease progresses, as it's severe insufficiency, those typically are very amenable to a minimally invasive mitral valve replacement. In this case, the aortic valve has already been replaced. So typically we would either approach through a small incision on the right side, or if there was some reason we were going back through the middle, we have an approach that takes us through both atria to get to the mitral valve. But at present, we don't have anything specific for this that's FDA approved. There are ongoing studies for all the other valves that you see here. But they all have caveats and limitations. So I would say probably, Kathy, if you're otherwise doing well, you're probably going to end up with another operation, but there are ways to do it that'll take the sting out of it for you. But it's possible that one of these devices will be available for you by the time you need it done.
Yeah, and Dr. Gerdish, real quick, I think folks online may have heard you say that you're going to be operating on an 89-year-old tomorrow.
Yeah, two of them tomorrow. I have two 89s.
Okay, so I'm sure they're wondering or thinking in their heads, wow, is the first one. But what's the oldest person that you've taken into surgery?
I think probably 94. I've had a couple of 94-year-old folks. One of them that jumps to mind is the 94-year-old guy that we did a minimally invasive mitral valve repair on, and he was back riding his bike the next week. But everybody's a little bit different, and we all have our stories, right? And then, I recently did a triple valve on an 89-year-old woman, and she's doing okay. It's kind of taking a little while to bounce back. She's going to be all right. She's up walking around. She feels okay. But it's going to be a little bit of an up and down for her. We just talk about all of those things and, the potential for the ups and downs after surgery, and we let people kind of decide if they're in for it. But there are different kinds of 89-year-olds. The two tomorrow, for example, one is a really robust guy, needs a double valve. And the other one is a little bit more frail gal. that has this horribly calcified mitral valve, but we don't want to just tell her she can't have surgery. We explain to her what the situation is, and then we take care of her. So yeah, we have the obviously the full spectrum. Sometimes I find myself operating on 20-year-olds, and sometimes I find myself on the nonagenarians. But it's all a matter of where the stage of their pathology they're in, what their frame of mind is, and what level of life they're trying to live.
Yeah, and we're going to get to another one of your specialties in a second, but let's go to a live question that came in from John, who asks, right on this topic, Dr. Gerdish, how is it determined if one is eligible for a minimally invasive surgery as opposed to a full sternotomy?
Right. So it really it depends on multiple factors. It depends on who the surgeon is. It depends on the nature of the pathology. Now, uh, these again can be long conversations, but let me highlight a couple of things. Number one, minimally invasive surgery is great. Love to do it. I think it's super important that we recognize that whatever operation we do is an all-encompassing procedure that takes care of every bit of pathology the person has. And if it means that I have to switch to a sternotomy in order to do 3 valves and a maze on somebody instead of just doing their mitral, then I switch to the sternotomy. Now, sometimes we'll do 2 valves through a small incision, and that's fine when it's safe and appropriate. But the most important thing is getting the right operation in the right size valve and the right procedure done for the patient. Now, this is also one of the reasons that I wanted to take some of that anxiety away from people. So, this week I did a few minimally invasive surgeries through the side, and then I did a few through the sternum. And the incisions are getting close to the same size, and the recovery is the same because of the way we manage the sternum. So usually, even for a sternotomy, we can keep the incision small or do a partial sternotomy or whatever. I mean, a sternotomy is a sternotomy. You just have to be able to manage that bone well and do an orthopedic repair. So the things that will decide that are who the surgeon is, what your pathology is, and being sure that there's an appetite to take care of everything that needs to be taken care of. And don't focus too much on the approach. Focus on what the global outcome is for the operation. There are ways to make the incision smaller, even for a sternotomy. We're even now working on making the scars go away. We've got some dressings that we're using that are really impressive in the way that they minimize the scar. So, and those are aesthetic things. I know they mean things to people, though. That's why I pursue them. I don't brush them off because they do mean things to people. But that's my answer. And you'll look at the patient will be scanned. You'll look at the anatomy. You see what the procedure is going to be. Like for example, that lady that I just did that I took the big calcium chunk out of and the big bar of calcium out of. I first met her and I was going to do a minimally invasive valve. And then I looked at the scans. I had this big bar of calcium. If I do a minimally invasive valve, the chances of me taking that big bar of calcium out and reconstructing the entire valve with a patch and extending the leaflets is small. But through a sternotomy, it's very high. So that's why we shifted. And she didn't mind. She had the same recovery as the person earlier that day that had a minimally invasive, thoracotomy approach.
Got it. And for the folks who do have to have the sternotomy, Dr. Gerdish, what percent of your patients are getting the rigid sternal fixation versus a wire?
So yeah, that's a great question, Adam, and it's starting to finally catch on a little bit. It's been 100% of our patients for several years. Once we studied it, again, we brought the devices in, we did the studies, we published those studies, we showed the hospital what the implications were. So we have this wonderful administration that really is really interested in outcomes, really interested in what we can do to expedite the recovery. And so there was buy-in from the hospital. So for 7 years, every human being that I or my partners has operated on has had rigid fixation. And we're even advancing that game now. I've got some new devices we're using in tandem with it. But yeah, I think that that's an important question, is what does that mean to the person's recovery and how important is it to the patient? Some people it may not be that important. But a lot of our patients, it's very important.
Great. Now, moving over to that other specialty of yours, I've learned an incredible amount from you, Dr. Gerdish, about atrial fibrillation. We've got two questions here. First one is from Dan. What is the difference between atrial fibrillation and atrial flutter?
Yeah, great question, Dan. And as a student of the most prolific and greatest authority in surgical arrhythmia management, Jim Cox, I do have answers for this. So, um, atrial flutter is essentially an electrical circuit in your upper chamber of your heart. It can be either one. that is just running. So you've got this circuit in the tissue that's running around and around and around. And every time it comes around, it sends a signal to the AV node, which is the gatekeeper between the upper chamber and the lower chamber of the heart. And that gatekeeper will decide how many of those signals are supposed to go through. So that's why when you look at that atrial flutter tracing, you see all those bumps. Those are what we call P waves. They're depolarizations of the atrium, the upper chamber of the heart. So that is an electrical event in the upper chamber of the heart. Now you can see they don't all get through. If they all got through, this patient's heart rate would be like that. But you have this gatekeeper, most of us do, a functioning AV node that only lets certain ones get through. So you've got this circuit. Now, why does a person have atrial flutter? So they have to have substrate for it. And the substrate is a pathway that's long enough and that recovers at the right pace so that as the signal comes around, the heart muscle is recovering in that area and also creating slow conduction so that it can come around and not hit an area that hasn't recovered. Because if it hits an area that hasn't recovered, it extinguishes. So you have to have the right substrate. So it has to be the slow action, the slow movement of the signal. Usually that means size too. The bigger the atrium, the easier it is to have this larger pathway that allows this to happen. And that's that one pathway. Now, if I add 3 or 4 more of those, it looks like atrial fibrillation. So atrial fibrillation is kind of the big brother. It is the more disorganized, it is the more prevalent tissue activation. And there's so many different ways that it's been studied that people are getting confused about it because initially it looked like it just meant that you had a lot of these large rotors, but now they're finding that there are smaller spaces that can generate the activity as well. So what we do know is that with isolation of the tissue for atrial fibrillation and with breaking those rotors for atrial flutter, we can get rid of the arrhythmia. And that goes back to Dr. Jim Cox, whom I mentioned earlier, who invented the Cox-Maze operation, which stands still as the definitive operation for atrial fibrillation. Atrial flutter is a little bit easier to address, especially if it's on the right side. On the right side, the electrophysiologist can almost invariably treat it. On the left side, it's harder for the electrophysiologist to treat it percutaneously. But that's the fundamentals of it.
Great, thank you. Down to Thomas's question. He says, are redo patients, I've never gotten this question before, are redo patients more susceptible to getting AFib? What precautions should I take?
It's actually a really insightful question because if you've already had heart disease and you're coming up on needing a reoperation, chances are you've got something that's going on where this valve that you have needs to be redone, re-repaired, re-replaced, whatever. So in that time span, there's a good chance that your atrium's developing more pathology. Now, there are some people that you cannot give atrial fibrillation to. They just won't get it. But most of us are vulnerable if our substrate changes. So as the atrium enlarges, as it gets more fibrotic, which happens as people have heart valve disease and progress in that pathology to the point of needing a reoperation, they are going to be more vulnerable. The other thing is there's probably a little more inflammation in the chest after a redo, and inflammation is one of the drivers for AFib. As far as precautions go, your physician may or may not want to use a preemptive medication. We use amiodarone for folks before surgery sometimes. And that seems to quiet it down. But then you can't do anything to address it yourself. This is just a matter of what the substrate of the heart muscle looks like and the inflammation around the time of surgery.
Great, let's keep going on. Real quick, Mark, got a live question from somebody says, I'm an 87-year-old male. I've got AFib for 10 years, leaking aortic valve, slight mitral prolapse, shortness of breath. Can I still exercise?
The answer is generally yes. The severity of the leak of the aortic valve would be important because if you stress that too much, you could run into trouble. But I would always advise people to exercise, but also within the construct of understanding how severe their valve pathology is. So that was something you'd have to ask the cardiologist or have somebody take a look at the echocardiogram. But if it's just and it's probably not leaking severely if they're being managed medically, in which case I would say, yes, you may still exercise.
Great. This question came in for Shirley. You addressed this earlier about the early outcomes for a redo using valve versus a surgical approach, in which you stated that as of right now, a surgical approach is showing better outcomes at this time. So unless you have anything to add, we'll move on to the next question.
Yeah, the only difference is that, as you might expect, if we look at the totality of them, there's an early mortality advantage to the transcatheter valve because you're not having surgery again. It's just early. But once you follow them a year or so, then the advantage falls strongly to having a reoperation with another surgical valve.
Great. Here's one about an implantable ICD. Marib asks, is it true that 25% of patients experience reduction in left ventricular ejection fraction after mitral valve surgery, resulting in the implant of an ICD? This happened to me. I was not made aware of this possibility. It has had a profound impact on my life. Please share your thoughts.
So it depends on which type of mitral valve surgery it is, of course, and it depends on why the pacemaker defibrillator was required. Implantable cardio defibrillator. So I assume that this is also a pacemaker. So there's a recent, actually, it's interesting. There's a recent study that was just published looking at mitral valve replacement or mitral valve surgery and the requirement for pacemakers. It was just published. And they could not discern a survival disadvantage to the patients who required a pacemaker after mitral valve surgery. This was really interesting to me because we do see a difference in survival overall for people who have aortic valve replacement and require a pacemaker. So why does it happen? Probably because with aortic valve replacement, the most common issue is that patients get they can develop left bundle branch syndrome, or they develop a pacemaker syndrome after having a pacemaker put in, and so they can have some disadvantage. Mitral valve, for some reason in this study, which was thousands of patients, they didn't see that difference. I would add that after mitral valve repair, pacemakers are extremely rare. Mitral valve replacement, 3-4% of those people go on to require a pacemaker. The pacemaker, though, is typically not because of a reduction in left ventricular ejection fraction. It's because there's a block in the electrical conduction pathway. So you can see these are different animals. Now, when people have a decline in their left ventricular ejection fraction after mitral valve surgery, usually it's in the subset who had a badly leaking valve. They had it for a long time. The left ventricle became overloaded, suffered fibrotic changes. Meanwhile, the heart has been working against this path of less resistance where it's pumping blood backward through the mitral valve. When you do the operation, you take that away, and a ventricle that may have been kind of in the normalish range before, it's like 50% ejection fraction, all of a sudden it drops down to 25% because it's doing what it can do. So that may well have been what happened. As far as 25% of patients, that's kind of a big number, to be honest. I think it's probably not quite that high. But the reason to have the defibrillator and to have the pacer, which I suspect is a BiV pacer, I'm not sure, but there are particular types of pacers that improve the squeeze of the heart if the patient has a particular type of conduction abnormality. Those are called biventricular pacers. Those devices can really help the heart recover. So I don't know that it's actually 25%. It's certainly not 25% of them go on to need a defibrillator. That's definitely not true. But there is a subset of patients who, after mitral valve surgery, especially if they've had a bad leaking valve, end up with requiring that because their ventricle shows its true colors. That's possible.
Great. Let's talk about something we talked about a lot today, Dr. Gerdisch. Let's talk about something I don't think we've talked about yet, which is aortic regurgitation. And Suzanne asks, I'm 63 with mild asthma, diagnosed with moderate aortic regurgitation a few years ago. Now I have mitral stenosis and tricuspid regurg. My ejection fraction is 60%, right and left atria and ventricles are normal size. I get out of breath and have occasional palpitations. Does moderate aortic regurgitation, we talked earlier about moderate aortic stenosis, but does moderate aortic regurgitation have anything to do with affecting the other valves? Am I good at just getting an annual echo at this point, or should I be more vigilant?
Yeah, so Suzanne, is a great question because you're trying to be insightful about your own process and you have some symptoms. Unfortunately, your case is a little bit interesting because you have aortic insufficiency, but you have mitral stenosis. So what would result in that in a 63-year-old person? So the first thing I would think of, quite honestly, is rheumatic disease. Did you have rheumatic fever as a child, even maybe not know it? Because in rheumatic disease, the aortic valve may not get stenotic and it might leak because the leaflets curl up a little bit and they don't close all the way. And then you find that looking at the mitral valve, as the leaflets thicken and lose mobility, you start to see mitral stenosis. You don't say how much mitral stenosis you have here. On the other hand, they could be different disorders. So you've got an aortic valve that leaks because the annulus is stretched out, where the leaflets attach. But then you also have calcium developing in the mitral valve that's creating stenosis. So in your case, with the fact that you have some symptoms, the two things I would want to do are I'd want to monitor for those palpitations anytime you have them. If there's a way for you to find out if you're having atrial fibrillation, I think that's important. People can have a few palpitations and find out later that they're having atrial fibrillation. Yeah, and in your case, I probably would be doing echoes every 6 months. I'm not going to speak out of turn for your physician, but once I see moderate, I typically want to see things every 6 months because an echo is an inexpensive, easy way to know if anything has changed. And you're trying to stay right on top of this. So the mild tricuspid regurgitation, I wouldn't worry about. The mitral stenosis, it depends how severe it is. My suspicion is it's mild. And then the aortic regurgitation, though, if it's definitely moderate, if it's truly moderate, then I would follow that a little bit more closely. As long as your ventricles and atria look normal in size and function and strain, I would add strain, then I would say, you can kind of chill and enjoy your life and you might deal with some mild symptoms. But if any of those things changes, any of those parameters change, then you have to think about doing something.
Great. And Mark, here's an interesting question. Just you mentioned earlier, and I think it's so important for the folks on the line to focus on this, is this idea of the lifetime management of your valve disease. And you may not have the right choice or the right idea at the right time, but you need to plan and think about what might happen. Here's one from Kelly. It says, in 2009, I had aortic valve repair for bicuspid aortic valve. Recently, a big increase in stenosis. At 56, what are my options? I'm too young. Am I too young for TAVR? Am I too old for the Ross procedure? Are there minimally invasive opportunities? Other than my heart, I live a healthy, clean lifestyle, yoga, and walk daily.
Wow, great case. So Kelly, yeah, this is something that can happen. I mean, we always hope that the repaired bicuspid valve is just going to last forever, but we don't know. And we know it's abnormal tissue when we repair it. So you got a pretty good run out of this valve. Now you're only 56. Yes, you are too young for TAVR. I'm going to just tell you that for sure. You are not too old for a Ross. So in people like you who are particularly healthy, they do get done in folks over 50. And if I'm being absolutely honest, because I've reviewed those papers, the results are a little bit mixed over 50. But you sound like a particularly healthy person, so it might be a good option for you. It might make sense for you. Just recognizing that at over 50, there's a little bit more chance that that pulmonic valve might not be usable. There's also, you have to deal with the potential for reoperation no matter what. So now the next question is, what do you do if you're not going to do that? So you're 56, you're healthy. And personally, I would probably think about an onyx valve, mechanical valve. You probably are averse to anticoagulation. You don't want to be in Coumadin. Nobody does. But, in my mind at that age, and I'm a little bit older than you, and I still would even personally lean toward an onyx valve because you can have a device that'll never change for you that you do have to manage with the blood thinner, but at least you're one and done. If you have a surgically implanted tissue valve, that's still acceptable at 56. The data says that your survival is not quite as good over the long run. We have a recent paper last year, Dr. Bowdish showed us that people under 65 probably still benefit from having a mechanical valve, but it's not unacceptable. But you would want to make sure that you have a good sized tissue valve that's going to last you a long time, and then potentially, maybe, if that's what you need later, a transcatheter valve in there. At 56, if you get a tissue valve now, chances are you're going to get another operation because you're really healthy and you're going to live a long time, especially if you're bicuspid. People with bicuspid valves tend to live a long time because they tend to be healthier. So as a subgroup, we have to think of them in terms of living into their 80s and 90s. So I would say, feel free to get evaluated for Ross. It's possible. Like I said, the data is mixed over 50. Personally, I would think in terms of an onyx mechanical valve because of the survival advantage. If you can't accept that, then get a big tissue valve. Minimally invasive depends a little bit on kind of the overall anatomy of things, but typically, if you've already had one sternotomy, for an aortic valve, typically we would use that sternotomy again, but then with the advantage of putting the bone back together in an orthopedic fashion so that you can just get back in action right away.
Yeah, great question,
I've had
Kelly.
plenty of people have reduced sternotomies that have told me this is so much better this time. So it just is what it is.
Yeah, that's a great insights and great question, Kelly. And we, out of respect for everybody's time, we're gonna end the webinar. But please don't hang up just yet. I want to go ahead and thank Dr. Gerdisch. Mark, as always, I think we could have gone on for another couple hours.
I got time.
We only have 60 some more questions to go. So I want to thank you and Nicole and your whole team there for taking such great care of our patients over the years. And to all the folks on the line, I just want to express my gratitude and appreciation for your commitment to your own cardiac care. We are here together as a community, and for me, there's no better time than doing these webinars and getting together and sharing these experiences with world-renowned physicians to coach us along the process. So I'm going to go ahead and end the webinar, and if you could just complete the survey that's coming up, we'd really appreciate it. Thanks so much, Dr. Gerdisch. Thanks, everybody.
Bye, everyone. Thanks for getting on.